Now we're going to talk about adolescence. This is the transition period from childhood to adulthood, and there are significant changes that go on with physical changes, cognitive changes, and psychosocial development. So the first thing we're going to notice about adolescence is that the changes that do begin to occur are pretty rapid, and adolescents gain in their aptitudes and their ability to gain autonomy, make decisions for themselves as they transition into early adulthood. What we also see in adolescence is the it's kind of a secondary differentiation. That is that sex role differences and gender differences are somewhat exaggerated in adolescence, somewhat by hormonal changes and also by the fact that they're transitioning more into adult-like relationships. So that's why we start to see sort of a return to a masculine imperative where you see more typically masculine behavior in boys and typically feminine behavior in most girls. But the first sign of puberty is the beginning of the adolescent growth spurt. So just like in early childhood, you see growth spurts periodically. In adolescence, you see a significant growth spurt. So there are a lot of growth changes, height, and these changes are different. They are differential by sex. So this is a point where boys have a tendency to outgrow girls in height. Also, boys are going to grow longer generally than girls by about a year or two, but girls are going to mature quicker than boys are by about a year or two. So the adolescent growth spurt in females is going to begin somewhere around 11 years old. Males are going to be about a year to 2 years behind them at age 12. Females are going to mature quicker than boys do, and most will stop growing in height quicker than boys and enter adulthood, physical adulthood quicker. Physical adulthood is when your epiphyseal cartilage plates at the ends of your long bones ossify and you stop growing. You don't get any more height after that. At that point, a person's a biological adult. For females, that can be as early as 15, 16 years old. Boys may continue to grow long after that, some of them in their late teens, early 20s. Because boys are growing quicker than girls are, they, in many cases, they're a bit more clumsy than girls are, and their fine motor skills not quite as good as their female peers. The brain reaches 95% of its full volume at the beginning of adolescence. So that means that all the neural pathways, myelinated pathways, and connections are about at their adult maximum when they enter adolescence. This can explain biologically why their aptitudes take a kind of a growth spurt as well when they reach adolescence. So even myelination of the brain, the critical period for myelination of the brain is 0 to 5 years old. The brain continues to form connections and myelinate all the way through the childhood into adolescence, and it reaches its maximum myelination when they get to late adolescence, or early adolescence, and then they'll be completely myelinated through adolescence into early adulthood. And as we talked about before, this is why you're going to see a significant increase in processing and aptitude. Adolescents can be really quick to encode information, quick to retrieve information. This is their what's called fluid intelligence, and they have a max of fluid intelligence, just like we talked about before. This is why their aptitudes are significant, and this is an opportunity moment for them to acquire a lot of skill and knowledge. Also, depending on what their exposure is to stimulus conditions, activities, and study, you're going to see a dramatic improvement in the neural efficiency or the efficiency of their processing. And this is due to synaptic pruning that continues to form real distinct neural pathways. And these neural pathways are what's going to give them their specialized brain functions. So it's this completion of brain development, the rise in aptitudes that are going to give them you're going to see this explosion in abstract reasoning ability and creativity in adolescence and increased processing speed. So this is due to the fact that the frontal lobe is almost fully developed. It's also going to lead to an increase in executive function. And executive function is the ability to elicit control over emotion. So you may find that adolescents are a bit more emotional. However, their ability to elicit control over emotion when prompted is improved by their improvement in executive function. The other thing you can see in adolescents, they have the capacity to be less impulsive, to delay gratification and set goals. And then we don't always see that because sometimes the social situation, the context doesn't really prompt them to do that. But when prompted, when they begin to work at jobs, when they're involved in school, when they're trying to achieve in activities like sports or academics or arts, the ability to delay gratification and set goals gives them the capacity to excel in those activities. Just a little review here. Primary sex characteristics are those characteristics that are apparent at birth. So babies with their diapers on all look the same, male or female. You can't really tell the difference because there are no differences outside the urogenital tract that you can see. So differentiation of the urogenital tract during gestation results in primary sex characteristics. Secondary sex characteristics are all of the kinds of characteristics that develop during childhood and then get exaggerated in adolescence. So secondary sex characteristics are those things that make females more attractive to males and males more attractive to females, and make distinct differences in males and females that can be seen in the rest of their bodies other than just the urogenital tract. So height increases more over males. In early childhood, it's common to see females actually, some females taller than males. Axillary hair grows in different places in males and females. Like males have chest hair and facial hair. And then there's breast development in females and wider hips in females. Broader shoulders in males and a narrower hips gives them a more angular appearance, which gets exaggerated during adolescence. And the pharynx lengthens in males, and that gives them a lower vocal pitch in most males. You see the onset of oogenesis in females. That's the maturation of oocytes and ovulation and menstruation. And spermatogenesis in males, which is the production and ejaculation of sperm that begins in puberty. And now, adolescents have a reputation for being real moody or having wide mood swings, and those are generally attributed to hormones. However, studies have shown that that's to some degree a Western idea. It's not consistent in other parts of the world across cultures. It varies from one culture to another, which indicates that there may be a socialization factor in that. Also, there's a tendency to form what may be a false attribution, and that is that when adolescents express any kind of an emotion, it gets attributed to hormonal changes. And that is, they hear a lot of feedback like that, that it's hormones or they're hormonal. The research doesn't really back that up, that their moods are necessarily totally a production of hormones. They found the same thing in females in general, and their over-attribution of their moods to their menstrual cycles. There were actually studies where they separated out the menstrual cycle on a calendar with reports of their moods and found a disconnect there. They did find that variations in mood with adolescents is primarily a function of variations in their social environments. When adolescents are around their friends, their peer groups, their moods tend to be much more positive than when they're not. So this tendency to over-attribute moods to emotion can become a self-fulfilling prophecy, because the expectation that their mood is the result of hormones can cause their social situation to actually be ignored. The more accurate predictor of their mood to be under-attributed and ignored because of the predisposed belief that it's a hormone problem. Also, beginning about 10 or 11 years old, kids start to hear that there's a prediction that they're going to become more moody and more difficult when they reach adolescence. And there may be some self-fulfilling prophecy there. Okay, let's look at eating disorders that develop in adolescence. And eating disorders, the common onset of development is in adolescence, most common in females. Anorexia nervosa is a relatively common eating disorder in adolescents in mainly females that involves an obsessive compulsive drive to spot reduce. That's a thing that we don't usually talk about with anorexia, but it causes avoidance of calories and strategies in an attempt to lose weight. But it is a type of an obsessive compulsive disorder because an obsession is a recurrent thought that is intrusive and uncontrolled, and that results many times in the resultant drive to behave in a certain way, which is a compulsion. So it's that loss of sense of control over thinking and behaving. The principal feature of anorexia diagnostically is a perceptual distortion and loss of ability to see sort of the overall gestalt, the overall body. And that's what I mean by a focus on spot reducing. Anorexics get preoccupied with some little part of their body that they try to shed weight, and as a result they can't see the overall state of unhealth that they're in when they lose too much weight. Symptoms, strategies for losing weight can include purging, which is vomiting your food after you eat it, use of laxatives, use of stimulants or appetite suppressants, and the avoidance of calories. Anorexia is only anorexia if you see significant weight loss, and weight loss to the extent that a person's under their minimum fat storage and they're starting to see what's called marasmus or muscle wasting. Anorexia is potentially life-threatening, and it's a disorder that, unlike other eating disorders, can result in a serious physical condition. So anorexics are basically starving themselves, many times starving themselves, or sometimes starving themselves to death. So What's critical about anorexia is focusing on the appropriate treatment for it. Anorexics, it should be referred for psychiatric care. It's a psychiatric disorder, and that means that it's essentially a thought disorder, a thought perceptual disorder. Thought perceptual disorders border on psychosis, and so they need to be treated with antipsychotic and antidepressant medications. And that's the very first thing that needs to happen, is they need to be immediately referred to psychiatry for antipsychotic and antidepressant medication, because depression is one of the components in anorexia. And then once you get medicines on board and can start clearing up their mental status some, then cognitive behavioral psychotherapy tends to be effective, but only when accompanied by medication. Many times they may require inpatient care, life-saving care initially, or an inpatient program, or more of an intensive outpatient program, because getting control over the eating disorder their eating disorder is just too persistent. So let's look at the differentials between anorexia and bulimia. Bulimia, also more common in females, is distinctly different than anorexia. And the most important thing about bulimia is to differentiate it from anorexia. Anorexia is the principal disorder, or the primary disorder. In other words, you err on the side of anorexia because it's the more threatening disorder. It's the one more likely to result in serious injury or death. Bulimia rarely results in any kind of a serious condition and doesn't as often require inpatient care. And bulimia is an anxious reaction to a sense of loss of control, resulting in binging and purging, which is taking in large amounts of high-calorie food and then vomiting it back up again. And then afterwards, usually after an episode of binging and purging, there's a deep kind of depression. Interestingly enough, when you vomit like that, you have a real intense moment like that, your brain secretes endorphins, so they get a kind of an endogenous reward for vomiting their food. Also, like other forms of self-abuse, bulimia serves as gate control for anxiety. In other words, it distracts the brain from other sort of depressive or anxious emotions, and in that way it becomes a negative reinforcer. Usually it's the first time they actually purge their food that they discover the kind of relief they get after purging their food, and that relief is a result of closing the gate to the anxiety and depression that preceded the vomiting. So they get that kind of reward and negative reinforcing effects of vomiting their food. Bulimics are more often females who've been molested or abused as children. And so they're subjected to a traumatic double bind in earlier childhood. And so that's why they've got some trauma as a result of things that occurred in earlier childhood and being exposed to too much stress earlier in childhood. Bulimics also should be referred for psychiatric care, but in most cases don't require an antipsychotic medication, just antidepressant medication. Keep in mind, though, that antidepressant medications are selective serotonin reuptake inhibitors or selective serotonin and norepinephrine reuptake inhibitors, and that action actually takes about 4 to 5 weeks to take effect. So antidepressants are not rescue medicine. They are a medicine that you have to kind of make a commitment to over a several-month period. So it doesn't do any good for somebody to take antidepressants when they're depressed, thinking it's going to immediately relieve them of their depression. Rescue care for depression, when somebody's suicidal or in an anxious, depressive state, is actually treatment of the anxiety. Anxiolytic medications like diazepam or Librium, those medications are rescue medicines. Xanax is a rescue medicine. And it's kind of the opposite of an antidepressant. You take those when you are critically anxious to relieve the anxiety in the short run, they are not all that good for long-term therapy because you can get a tolerance to them and they can ultimately make your anxiety worse over time. So dependence on benzodiazepines, which are anti-anxiety medications, is really, really common in the addictions world. So treatment for bulimia. Bulimics tend to respond very well to cognitive behavioral therapy sessions by a therapist specializing in eating disorders. And this includes assertiveness training and trauma care to treat their bulimia if it's paired with a traumatic reaction, to treat it more as to treat it with some of the same strategies you would for post-traumatic stress disorder. But assertiveness training seems to work real well with bulimics because when you do assertiveness training and train them to take control over their relationships and situations in their life, it tends to drive down that prompt that loss of control has to binge and purge. You'll notice that in some adolescents you see self-abuse behavior like the cutting. That's similar to what you're seeing in the anorexics and bulimics. Bulimia involves taking in large amounts of food and then purging that food. But you see purging in both anorexics and bulimics. So as far as the differentials, the most important thing about it is that the default for an eating disorder is anorexia nervosa because it's important to treat it even if they're binging and purging and have the symptoms of bulimia. If they're shedding weight and have that cognitive distortion, preoccupation with some little part of their body, and they're taking strategies to try to shed pounds, like taking stimulants or things like that, they should be treated as an anorexic, which may include hospitalization, but it's a higher level of care that they're going to need. Bulimics also, unlike anorexics, bulimics respond well to group therapy. Like pretty soon after you start therapies with bulimics, you can put them in group therapy. Anorexics need to really be focused in an individual therapy setting until they get further down the road with their anorexia, and then you could put them in a group setting with other females that have had childhood traumatics exposure. So moral development begins with actually a theorist that came up with stages of moral development, and that was Lawrence Kohlberg. But to really understand Kohlberg, we have to go back to Piaget, because Piaget addresses moral development before Kohlberg does. Kohlberg is a cognitive psychologist, and so he's relying on Piaget's theory of cognition to develop his theory of morality. Well, Piaget had talked about how, with regard to moral reasoning, young children are heteronymous in their morality, which means that moral decisions come from authority figures or people that have more power than them. Threats of punishment, and they don't have, or threats of punishment are more of the kinds of controls they rely on, and rewards. And they don't have internalized rules or moral principles. And this contrasts on a continuum with autonomous morality, which you're going to see later in childhood, where moral decisions are based on internalized moral principles. These are going to be schematic constructs of morality that they've internalized by being exposed to adults and seeing moral decisions and how they think about where moral decisions come from. Kohlberg took Piaget's theory and formulated a set of stages. So pre-conventional morality is Kohlberg's first level of morality, and it's based on punishment and reward. So it's only obedience to authority and some type of exchange theory, like I'll do for you if you do for me. It's Piaget's heteronymous morality. And interestingly enough, it's Julian Rotter's external locus of control. So their location of control is outside of them, and they don't have internalized kinds of mechanisms of control. Now, adults can be pre-conventional. Many that are involved in criminal behavior, con artists, people that have difficulty empathizing with others, that are real self-involved. They tend to be pre-conventional in their morality. So they're childlike in their morality, but as an adult, they can be dangerous. So then they progress to level 2, which is conventional morality, or what's called rule-governed behavior. And this is where they can kind of internalize social norms or the expectations of others. They can follow rules to maintain order. This is Piaget's sort of intermittent between heteronomous and autonomous morality, where they have some self-control, but it's still dependent on the rules applied and exhibited to them by other people. This is also when Julian Rotter's locus of control is still pretty much external. It relies on other people's expectations and rules. Then Kohlberg's level 3 morality is post-conventional morality. This is when they've internalized principles of right and wrong, and they are not actually dependent on rules or feedback from the environment. It's a reasoned adherence to social contracts only when they're valid. So there's some critical thinking about moral decisions that are made here, like, is the rule a valid rule? The highest level of morality is internalized abstract principles of right and wrong. And this is when someone acts only on their internalized principles and not on the environment or the contingencies. This is Piaget's autonomous morality and Julian Rotter's internal locus of control. So examples of post-conventional morality are when you see someone that at their own risk makes a moral decision that can render negative consequences for them because it's right. And it's also doing right when there's no contract, like when in absence of expecting to get something out of it. So there's no exchange theory here. They just do right because it's right. And there's also quite a bit of consistency in people that are post-conventional. So they tend to be consistent across situations. When faced with enormous pressure from other people or the threat of social rejection or negative consequences, this is the sort of Gandhian morality, where you're going to suffer consequences and go to prison, but you still hold the line on your beliefs.